Dr. Tomar, come over. Stage 1 of revision TK, removal of fixed implants.
Good evening, everyone. And my presentation is on extraction of well-fixed TK implant and antibiotic spacer application in first stage revision. That is the first part of the two-stage revision, which is gold standard for revision surgeries in case of prolonged PJ infections. So important is to identify the bug and antibiotic sensitivity to this bug. And the challenges during this surgery are minimizing the bone loss while during removing the metal implant, thorough debridement and collecting the samples adequately, and simultaneously protecting the patellar tendon also. The cement spacer are used to maintain the joint space, give partial mobility to the joint, and proper antibiotic delivery to cure the infection. The spacer can be static or articulating, and articulating can be prefabricated or fabricated peroperatively with antibiotic-loaded cement. So this is a video presentation in a usual manner with tourniquet or without tourniquet in a midline incision with medial parapatellar incision, and we can give a small quadriceps nip proximally in the quadriceps for better eversion of the patella and to protect the patellar tendon. We collect the samples, and from the suprapatellar region and remove the entire infected synovium, take the samples, then come to the medial medial part of the proximal tibia. There is a periosteal elevation till posteriorly, remove the tibial implant, and make the process easier and easy exposure. Then we try to remove the femoral metallic implant, and that has to be done to disengage this in the interface between the metal and the cement, and try to avoid the interface of the cement and the bone. So with the soft blow hammers, I blow with the thin osteotome or the thin blade saw, we try to disengage the metallic implant from the cement. And this interface, we try to disengage this, and in the superior part, in the anterior part, we can disengage this with using a giggly saw. Then when we think that this is adequate disengagement has taken, then we can take it out with the extractor importment, but they had to be very gentle blows and never too hard, otherwise there will be a significant loss of bone and may take out a chunk of bone along with the cement. So when it was not removed, then again try to find out where it is stuck, and after certain time, then we find that we are able to remove it, then connect the samples, and if medullary canal is open, so take samples ideally from the medullary canal also. In the same way, we try to we dislocate the tibia anteriorly, and try to disengage the metallic tibia implant. In the same way, interface between the cement and the metal with using the thin saw blade and the use of the thin osteotome, try to disengage this with proper protection, and we look for this that whether it has become loose or not, and gradually then we again apply the extractor, try to take it out, and that in this we took it nicely, and the cement is intact. So there was absolutely no loss of bone, and then cement is removed in bits and pieces using the again thin osteotome, the gauzes, and the osteotome, and the cement is removed from the medullary canal as well, and these samples are taken from the medullary canal. So after removing the cement from the medullary canal, and we clean it out, and then suction lavage of the entire surfaces is done. Remove the leftover cement and the granulation tissue, take all the samples, almost 6 samples from medial, lateral, posterior, and the medullary canals are taken. And then come to the patellar side, the debridement of the infected tissue, the granulation we do, and remove the patellar button with the thin saw blade again. And after removing this thorough debridement, take the samples for the samples, and clean it out with the help of nibbler. So after this, with thorough lavage and debridement, we come to the making of the fabricated spacers. So fabricated spacers are the size of the implant that we removed. Maybe it's a little smaller, never bigger. And the antibiotic loaded cement, thus we prepare this articulated femoral spacer. After this is prepared, we apply it on the surface like a trial, and we look for the tibial thickness. After we look for the tibial thickness, and after this, the same antibiotic loaded cement, we prepare the tibial articulated spacer. And in the meantime, we can just clean the raw areas of the bones, dry it out, and then after proper cleaning, we check. Again, we try, apply the spacer, and in a trial mode, we look for the stability of the joint and look for the patellar stability also, patellar tracking also. Then after proper this thing, we apply the cement, antibiotic loaded cement again, but this is very poor cementing, never in the intermedullary canal, only on the surfaces, and in a doughy state, we apply the cement over the tibia and the femur. So this gives a little stability, but can be removed easily after when it has to be removed. Same way, we straightening the joint, look for the patellar stability, and remove the leftover cement there. So this way, then wound is closed over the drain. So this was all about this first stage revision, and to conclude, outcome goals are infection control, bone stock preservation, and maintain joint stability, and second stage revision preferably between 6 to 12 weeks post-surgery when complete infection control is there. These fabricated articulated spacers give good range of movements and better rehabilitation during that period when second surgery took place. Thank you very much for the patient hearing.
Thank you, Dr. Tomar. One problem I face with articulating spacers is I can never get that kind of stability because they're fixed sizes. So you put on the femur. Now, how do you make it very tight fit so that there's no medial lateral instability?
Yes, sir. Like fabricated spacers, this is a problem.
There are CR types.
Yes.
There are CR types. There's no peg there. So sometimes they're very unstable. They're mediolaterally not that stable.
No, sir, they are stable. They are very stable because the fabricated spacers, we use the same kind of implant, same size we use, and then fix with the cement also. And the tibial spacer that we are taking, that is, we are making during operation only. So these are absolutely stable. The patients are so happy.
How do you decide thickness of the tibial base plate?
When we prepare the femoral spacer, femoral mold, femoral component, and then we again check with this molds of the tibia.
They come in a couple of sizes, not only one size. They come in a couple of sizes, and also you
multiple
can increase
sizes.
the thickness. Amount of the cement also you can put more, and then according to the flexion and extension gap, what you see on the table, whatever way, you can just put a correct size of thickness and the correct size of femur as well. So they're quite stable, one. Second, they tend to heal with a lot of fibrosis. Usually they're quite stable. And I don't think so there should be any...
No, it is not because of fibrosis. Yeah. Because we are removing the entire fibrosis there. But when we apply the femoral component, and then we using the trial to look for the thickness of the tibial component.
Yeah, I think that's the point.
It becomes so stable, the patients are so happy, because I happened to do this in one case. Patient was 100 kgs of patient, bilateral TKR done, infected patient, and revision had to be done in both the cases, and we were very scared. So in those cases, I did that, and patient was so happy. I have done second stage revision as well. This case, patient was absolutely happy.
So after putting femur, you put a tibial trial.
Yeah.
Yes.
Trial.
Yes. And then accordingly fabricate the tibial space. Tibial.
And then
This is
fabricate.
the Heraeus system you're talking about.
Yeah.
The Heraeus system.
This is Copal system.
Yeah, there's a Heraeus which I use.
Yes.
It's very similar. The femur comes in 3 sizes: small, medium, large. So you can more or less fit it reasonably accurately. In females, you put small. In males, you can put medium or large. Now, once you put
Small,
the
medium, large in what dimension?
I don't exactly know, but it's approximation.
So
it's not like your definitive implant.
It has to be either the size of the component that we removed,
Then
or a
what you do
little
is-
smaller.
Then what
That's
you
all.
do is once you put the femur,
My issue is adequate height to make it a good construct.
I think
Height.
it's a pretty good
I'm talking
construct.
about height.
And then
I'm not talking about mediolateral.
The
Then-
height means like we make it, use a trial. The different thick spacers are there. So the same thickness tibial spacer is made. Same
and then
thickness
and
tibial.
then at the end you are cementing it. So
I can show it in like.
in fact, some of the patients never came back. They lived the rest of their life with that
the
implant.
second stage, the first stage, I did both simultaneously. First stage revision in both
Like
the
you can
both the
make up
knee.
like your
The
trial implant
second,
and, there's no issue about the
yeah,
stability.
this-
Obese patients, I had one patient who had a fracture of the tibial, the tibial part.
tibial part.
Yeah.
No, that fracture will take place, of course, because one stage was done and then patient was not ready for the second one. Because the patient was happy, but he was insisted that this is not going to work for long. So after 3-4 months, after 2 months, the first stage was, second revision was done, but patient was not ready for the second knee because she was happy. See, I'm walking and I'm doing everything. So, but then patient had to be convinced. Otherwise, again, you will be in the same situation.
Okay.
Yeah, because there is absolutely no bone loss.
Dr. Tomar sir, have you seen case infection in spite of doing antibiotic loaded cemented spacer, and all you have treated all the cases of infection well, but have you seen any cases in spite of that doing the infection again?
Yeah. There are cases like
So,
if
and
you
that kind- this
then
kind
you
of
need to
cases, how
Repeat.
to
Repeat.
again cemented space.
Yes.
again same. Same.
To change anything, fixator, any other thing, removal out that.
No, it is same again. Revision
Again,
first
same
stage.
procedure again.
Okay, so I think we can proceed next. Dr. Sanjeev Kumar. Is it you?
No, not me.
Sanjeev Kumar.
Good evening, everyone. I will be talking on TKR in post-infection stiff knee. Okay. So, the stiffness in post-infection knee joints are because of bony deformities, the ligamentous contractures, previous surgeries and scars, severe pain, fibrosis of quadriceps muscles, posterior capsule contracture, intra-articular and extra-articular fibrosis, and patellar baha. The challenges we face while performing TKR are that knee is stiff, so flexion up to 90 degree or beyond is not possible or difficult. Identification of joint line may be a problem. Patella may be adhered to the underlying bone. Quadriceps and rectus femoris muscles are adhered and very tight. A very tight joint may lead to difficult knee subluxation or dislocation, and patella eversion may be very difficult. Chances of tibial tuberosity avulsion and patellar tendon rupture are always there. Soft tissue balancing will require generous release as per deformity to create equal flexion extension gap, and bony deformities or bone defects may need special attention. How to approach a stiff knee? A detailed clinical examination is must. Decide the implant as per need and always keep constraint on hinge implant on table. According to the stiffness, you may have to start surgery in extension while taking standard midline parapatellar approach. So after arthrotomy, patella may be adhered to the underlying bone or tissues, and it may require release or osteotomy. A thorough debridement of synovium from both the guttus and the suprapatellar area is required to visualize the joint line. Slowly one should attempt to flex the knee after raising medial subperiosteal flap and releasing tight structures as required. This all process of release of soft tissues and process of flexing the knee should be done very gently. One may need to do a quadriceps jet lengthening or snip of the quadriceps to evade the patella. Sometimes, because of the tightness of the quadriceps mechanism, tibial tuberosity may also be required so that one can evade the patella and flex the knee. If there is contractures in extension, then you need to do a lot of releases of quadriceps muscles, and as a lot of debridement from the pouches and the gutters are required. All the soft tissues are in and around the knee joint must be removed so that one can have a flexion of the knee. If you have a flexion contracture, then osteophytes all around the femur and the tibia must be released, and sometimes you may need to release the posterior capsule behind the knee to get a extension. If one is not able to do get a flexion of the knee even after doing all the releases, one may start doing the knee. One may take a distal cut of the femur first, and once you take a femur cut first, you may be able to flex the knee, and you can proceed accordingly. After flexion of the knee, you can proceed with the standard manner of TKR, because you need to balance the flexion and the extension gap as in a standard manner. After you put the trial, you need to see the patellar tracking, because in all these stiff knee, the patella is not central always. So as per the requirement, mostly this patella are subluxed laterally. So you may need to do a lateral retinacular release inside out to get the patellar tracking correct. And then after doing this, you can put implant and do standard closure of your joint. I will be showing two cases. One case, this is a 28-year-old young female, a post-septic arthritis knee, healed, very painful knee, have very less arc of motion from 10 degree to 30 degree of flexion, very painful knee. As we started and we did arthrotomy, the patella were adhered to the underlying structure. So after release of this patella and all the fibrotic tissue into the suprapatellar pouch and into the gutters, we were able to sublux it. And after all releases, we are not able to get an adequate flexion so that we can put our jigs. So we started with doing distal cut first. And after this cut, we did our knee in a standard manner. But after putting our implant, we see that the patella was not tracking correctly. So we need to do this lateral patellar retinacular release. And after doing these releases, we are able to have a assisted central tracking of the patella. And we are happy with this tracking. So we closed this knee, and this is how we got the post-op X-rays. After almost 3 to 4 months of this surgery, patient is having from 0 to 90 degree of flexion. She is pain-free now and happy patient. Another case, this was a 55-year-old lady, healed septic arthritis right knee with valgus deformity. We planned knee in a standard manner. So once we opened the knee, we were welcomed with unexpected multiple cysts into the proximal tibia and the femur also. Fortunately, these all were contained defect of the tibia, and in the femur side, lateral condyle, the defect was less than 5 millimeter. Although we were not prepared with the bone graft because we missed this cavitated lesions on the pre-op X-rays, and we have also not done the CT scan for this case. So we filled the cavities with the graft available on table, and then we prepared our knee, and this is how we got away with this case. And also after 6 months, this is a patient, we got a good clinical outcome, and she's a happy patient. So the take-home message for stiff knee is that they are very challenging situation. Soft tissue needs more attention and careful, and required releases to be done for optimal results. Slow and sequential releases will help in attaining required soft tissue balance, and may need a single procedure such as quadriceps snip, tibial tuberosity or short may, patellar releases, etc. And also may need constrained implant sometimes, depending upon the situation on route. Thank you, sir. Thank you very much.
Thank you for very much for such a nice presentation. So the next and the last talk is by Dr. Daksh Gadi, and that is on revision in infected TKR. Revision in infected TKR hinge versus TC3.
Thank you for staying. Male patient came to me with severe knee pain. He had a history of TKR done 2 months back, and he had pus discharging sinus. He had undergone insert exchange on the 5th post-op day by the primary surgeon. So on table, severe instability was noted. Multiple cultures were sent which showed multi-drug resistant Acinetobacter infection. Revision stage 1 was planned. I had done first arthrotomy and given a wash. So So stage 1, the implants were removed and articulating spacer, mobile spacer was made on table, mixed with antibiotics. This is the mobile spacer, and as the Acinetobacter was sensitive to meropenem, which is not heat stable, so we had mixed it with stimulant, and colistin was put in the antibiotic spacer, and wound after 2 weeks. Stage 2 was done at 2 weeks. 3 weeks of IV antibiotics were given, and 3 weeks of oral antibiotics were given, and 2 consecutive CRPs were normal. This is the articulating spacer, and on second stage, good rectangular extension gap was there. But there was a bony defect in the posterior condyle, and distally, lateral condyle, there was a distal defect, bony defect, so augment was also used. So these are the post-op x-rays of the patient. So as it was being discussed, that patient can be mobilized on a mobile spacer and articulating spacer, and it is very stable. So after first stage only, the patient was mobilized, and at 15 months post follow-up, patient is having good range of motion of around 0 to 90 degree, and he is walking well. This is the second case of a 60-year-old female who had undergone bilateral TKR elsewhere. She had a history of pus discharging sinus from left knee, and difficulty in walking was there, severe pain and swelling in the left knee. So similar stage 1 was done. The implants were removed with minimal bone loss, and articulating spacer was put, and even stimulant was put mixed with antibiotics. She had a Klebsiella infection, and both colistin and meropenem were put in the spacer. So the wound healed, but there was persistent CRP high and serosanguinous discharge at 6 weeks. So as it was being asked in the previous talk, that spacer should be replaced. So we replaced the mobile spacer with a fixed antibiotic spacer. Sometimes the mobile spacer is not very stable, like Maheshwari sir told. So in such cases, if we immobilize the patient with a mobile fixed spacer, chances are infection may heal better. So after that, the revision was done. There was in the extension part, there was a good extension gap was there, but in flexion it was not very stable because the lateral condyle there was bony defect, and but the collaterals were intact, but big lateral condyle defect was present. TC3 was tried, but even with larger insert, knee was unstable in flexion. It was dislocating after around 50-60 degree of flexion. So femur sleeve was used, and rotating hinge knee was done. This is the post-op X-ray. And this is the 13 months follow-up. Patient is having good range of motion. And walking video, this video is of around 4 months post-op, and this is around 8 months post-op. So the take-home message is backup of all kinds of implants should always be present while doing a revision. TC3 hinge, or sometimes you may need a mega prosthesis. Sometimes 3 stages may be required, and every 6 weeks patient should be changed for better results. Thank you.
So any questions or comments by anybody? So anybody doing one-stage revision for infected knee? Not yet. Okay.
But there is a trend towards that.
Yeah. We are all a little bit hedging, like I think that's one area to explore.
I think one of the problems we are facing is isolation of the bug. That is one of our difficulties, and I think that's absolutely mandatory if you are planning a one stage. Isolation of the bug.
This is second case. Skin looks is not good condition. I think in this case, do you think all the panelists think the muscle flap need? And
No,
because
the wound
is inside and need to be a good vascularity.
But wound is well healed. There is no skin problem in the patient.
So that's an important question which should cross your mind. After every revision, the skin becomes plus minus. you should have a low threshold of taking a plastic surgeon consultation at least. But once you open up and you have done a good knee and you can't close it, or if you close it by pulling and pushing, you are in trouble. So always after one or second knee surgery, and if you are doubtful about the condition of the knee, it's a good idea to take a plastic surgery consult. And I have a low threshold to call them and do whatever. They do all the repair, they do the closure, they do whatever. Because I don't want to close it by pulling and pushing, but that doesn't work. And even if it works, they start bending the knee, it breaks down again. So particularly knee threshold for involving a plastic surgeon is very low. But there is hardly any skin there. So you raised a good point. If skin condition is not good, don't mess around with closing it, come what may. Breathe, take whether it is heal. It will not heal, it is better to involve a plastic surgeon.
Thank you, sir. Sir, Dr. Sandeep, if after surgery, after TKR and patient presented after 3 months with you with residual flexion contracture, after surgery, patient presented after 3 months with residual flexion contraction, what to do in this kind of cases? Patient said कि मैं daily physiotherapy कर रहा था लेकिन मेरा पैर सीधा नहीं हुआ. उस condition में क्या कर सकता है?
Was it your case to start with or somebody else's case?
मेरे case में
So okay. So let me tell you. So this is a very common problem. We discussed this in the morning. Hidden flexion deformities are ignored, thinking that will be corrected by physiotherapy. A 65, 70-year-old, you cannot correct flexion deformity by manipulating every day. I call it torture session. So don't leave opportunity to fix it there on the table. And if there is a tendency within 2 weeks, if there is a tendency to keep that knee in flexion even 5-10 degree, become very hyper with the physiotherapist, with immobilization, some kind of a push knee splint, I call it. Push the knee. If you let it be for 3 months, then you have missed the bus. After that, no physiotherapist can do anything. The only solution will be take the patient to anesthesia and gently manipulate. If you manipulate too aggressively, you can also cause fracture. So it is only up to 4 to 6 weeks you can correct a flexion deformity by manipulation. After that, it is very risky. And sometimes the flexion deformity may be actually because you are overstuffed the joint. Instead of 8 spacer, you have put 10 spacer. And you miss that, you have left some 5-10 degree flexion deformity on the table. That cannot be corrected by any manipulation. You will cause fracture. So that's why I asked whether it was your case. So if somebody has done a case, he has left a flexion deformity on the table, not even God can correct it later. Because it is created on the table by overstuffing. Understand? But 3 months is too long. I manipulate my knees maximum 6 weeks. If 6 weeks I am not getting full extension, no more torture session. It is torture in the OT with under anesthesia, so that they don't have pain.
Then how to treat this case?
So this case, 30 degree flexion deformity, I will definitely take him to anesthesia, gently examine and see what. Of course, first X-ray, because there should be no new bone formation anywhere. Under the MCL, lateral, medial, so there should be no bony reason for the deformity. We know in arthroscopy, in the front, at the back, medial side, lateral side, no ossification. Once there is no ossification, it is a soft tissue contracture. You can still try manipulation. Even if you get 50%, stop there. Take him again after 3 weeks. Manipulate again. So manipulation is the only answer. You can't do anything else except. Posterior capsule release can be done as a desperate situation, which we do.
By arthroscopically, you want to say? Sir, I don't have this kind of experience.
Any role of hamstring kind of percutaneous release to correct the deformity?
No, this is all interarticular adhesions, periarticular adhesions. Yes, so sometime I have thought, not arthroscopy, but open posterior release. Suppose I manipulate, nothing happens. What do I do? There's no choice but to do an open posterior capsular slit. You can do it very carefully, medial side incision, retract out the vessel in the front under vision, slit the capsule and then manipulate. Ultimately, it will be manipulation.
So, no flexion deformity should be left on table. And I usually ask my patient to walk with heel strike first and then. So this what Professor David Chun used to tell me in Malaysia, that he always asked his patient to walk with heel strike.